think we already have 40 participants. Let's begin. So, good evening, everybody. We have joined back after Diwali. I hope this Diwali was happy and peaceful for everybody. And we are beginning now with infections of the nervous system. And after going through question papers for almost last 15 years, I decided to choose those infections which are more common for our scenario because the other ones are fairly, the literature is fairly well available even in the standard Western textbooks as well as journals. So you are already aware of our schedule today. Without wasting any time, we will begin with our first question. Obviously, the commonest, one of the commonest dreadful infection for India, neurotuberculosis. Its current diagnosis and management, which will be delivered by Dr. Manan Mehta, who is our consultant neurologist from Vadodara. I will hand over the session to Dr. Mehta. Please.
Can I share my screen now?
Yes, yes. You can begin now.
Am I audible, sir?
Yes, maybe slightly louder, and that should be good.
Okay. Good evening, everyone. Thank you for this opportunity given to me to speak on CNS tuberculosis. This is mainly focused on a theory-based discussion where you have short questions for 10 marks. So that is how I have prepared my slideshow. Now, not wasting any time. It will be just briefly discussing clinical features and spectrum of CNS involvement, how to diagnose CNS tuberculosis, and management of the same. Broadly, we classify this classification covers the entire spectrum of CNS involvement via tuberculosis. It can be classified as intracranial, spinal, HIV plus CNS tuberculosis, drug-resistant CNS tuberculosis, and miliary plus disseminated CNS tuberculosis. Mainly, what we commonly see is the intracranial and spinal tuberculosis. Of course, HIV is also now rampant and coming up with CNS tuberculosis. Drug resistance is still rare, or maybe we are not able to pick up early. But commonly, the intracranial involvement is tuberculous meningitis, tuberculous meningitis with miliary cox, tuberculous encephalopathy, tuberculous vasculopathy, and space-occupying lesion like tuberculomas or brain abscess. In spinal tuberculosis, it will be port spine with paraplegia, tubercular arachnoiditis, spinal tuberculomas, and spinal meningitis. Spinal meningitis is rare. HIV associated with CNS tuberculosis is the third category. Drug-resistant CNS TB, fourth, and fifth is miliary with disseminated tuberculosis. Commonly, what we commonly see practically as well as in theoretical point is tuberculous meningoencephalitis, where we stick to basics. Symptoms are fever, headache, vomiting, constitutional symptoms like anorexia, weight loss, and altered consciousness. Signs would be neck rigidity, confusion, seizures, cranial palsies, hemiparesis, paraparesis, altered syndrome, and coma. One more point what I wanted to highlight in this presentation was we commonly see vision involvement in CNS tuberculosis. Now, this was my Viva question that why vision is involved, how many ways vision can be involved in CNS tuberculosis. So I wanted every participant to know this. One is most commonly the optochiasmatic arachnoiditis, which is nothing but basal exudates around the optic chiasma, which involves the optic nerve and optic tract. Second is optic neuritis. Just like inflammatory optic neuritis, tuberculosis can also cause infective optic neuritis. Third is neurohidradenitis. Now, cora tubercle is considered to be a pathognomic of neurohidradenitis secondary to tuberculosis. Fourth cause of vision involvement is ethambutol toxicity. Long-term ethambutol toxicity in some patients may cause maculopathy. And fifth, although rare, but because of raised ICP, chronically raised ICP of tuberculosis and hydrocephalus, there will be papilloedema and secondary involvement. So this can be a Viva or a theory question. How do we grade a CNS tuberculosis or TBM? Grade 1, grade 2, grade 3. Grade 1 is nothing. Patient is diagnosed to have TBM, but he is alert and there are no focal deficits. Grade 2 is there is a GCS of 15, but with focal deficits like either hemiparesis or paraparesis, or there is cranial nerve involvement. Or second part is grade 2 is there will be GCS less than 15, but it is more than 10, that is 10 to 14, with or without focal deficit. Grade 3 of tuberculous meningitis is less than GCS less than 10, irrespective of any focal deficits or not. What are basic complications of tuberculosis? They can be broadly classified into three main complications. One is hydrocephalus, communicating or non-communicating. Here I would just want to point out that hydrocephalus is initially classified as obstructive and non-obstructive. Non-obstructive as in what we see in NPH, but obstructive tuberculosis is an obstructive hydrocephalus. Only thing is communicating or non-communicating. Now communicating will be where the level of the lesion is around the arachidoid villi because of the arachidonitis. So communicating all four ventricles are open. So the size of the ventricle is enlarged. All the four sides of the ventricles are enlarged. And non-communicating would be of the fourth ventricle will be normal and the remaining three ventricles are enlarged. Second complication is optochiasmatic arachidonitis, and third is vasculitic infarcts. So in this picture, we can see this is the MRI of a patient with tuberculous meningitis who developed a vision loss. Now this is very classical, a very textbook, very book written picture where you can see basal tuberculomas as well as some basal arachidonitis in the sylvian feature and in the parapontine and the cisternal involvement of the basal exudates. Now, how do we diagnose CNS tuberculosis? CNS tuberculosis is mainly diagnosed by neuroimaging and CSF study. In CSF study, we do the routine analysis, that is the cell, TCDC, protein, sugar. We do the microbiological analysis of the AFP, acidified bacillus, and then we do the molecular analysis. In imaging, we commonly see the neuroimaging and the chest imaging. Routine analysis would be CSF would be lymphocytic pleocytosis and the lymphocytic pleocytosis, where there will be some raised WBCs in the CSF and it will be lymphocyte predominant. However, in early stages, we can get some neutrophil predominant also. Proteins are raised, sugar is low, traditionally 2/3 less than the matching sugar of the blood. But still, such pictures can be found in other mimic infections like fungal or partially treated pathogenic meningitis or non-infectious etiology like vasculitis, rheumatoid arthritis, and malignancies. Second part, apart from routine analysis of CSF, is CSF microbiology. CSF microbiology is basically identification of acid-fast bacilli either by Zn staining or culture. This is the most definitive diagnosis. Now, coming to Zn staining, now this is very easily available. This is a low-cost thing. It is fast. Its turnaround time is around 2 hours. However, it has a lot of disadvantages. One is it is the reliability is very low. There is a very low sensitivity. It cannot differentiate between a drug-resistant or a drug-sensitive strain. Neither it can differentiate between a dead or a live bacilli, nor it can differentiate between a microbacterium or a non-microbacterium tubercular bacilli. How do we improve the diagnostic yield of the Zn staining in CSF? One is we examine larger volumes and we examine on several days. Second is we examine the deposits of centrifugation of 10 ml of CSF at least. And the examination, the microbiologist who is examining should be examining these specimens for at least 30 minutes. Second, in the microbiological analysis is the culture. CSF culture, this sensitivity is around 25 to 70%. However, it is high specificity. The culture of the Mycobacterium tuberculosis from the CSF is considered to be the gold standard for diagnosis. Simultaneously, along with the diagnosis, we can do a drug sensitivity testing with this culture. Nowadays, rather than the solid media, the liquid media are less time consuming and have a better sensitivity. However, the turnaround time is quite long. We have to wait for several weeks till we develop a definitive diagnosis. It can be the sensitivity is low, however, the specificity is high. Liquid cultures can be biohazardous. Third part of the CSF analysis is the molecular analysis. Now, this is frequently used. It is not any latent method. We are using at least since last more than 5 years everywhere in the world. Now, these are PCR-based methods, where the first one is nucleic acid amplification test. It can rapidly detect Mycobacterium tuberculosis in the CSF. The turnaround time is only 3 to 6 hours. It remains positive up to 1 month after receiving AAT. And it has a very good specificity. It is around 100%. However, the sensitivity is around only say 56%, and the standardization of the commercial CNS commercial test is difficult. Second part, which we now use very commonly, is the gene expert. Now, the advantage of this part, this test is the gene expert. Along with the diagnosis, we can see the rifampicin sensitivity also. I mean, sensitive or resistant also. Now, the turnaround time is around 2 hours only. And this is a very easy to conduct test. There is no major training required for conducting this test. The sensitivity is much good, better than the nucleic amplification test. It is around 80%, and specificity is also fairly good. It is around 86%. So this was talking about CSF. Now coming to the second part, that is neuroimaging. Now we see although MRI is frequently available, but many a times MRI is not available, and we do a CT contrast where we see some basal exudate, where we see some hydrocephalus or cerebral edema, where the gray white matter junction is not easily visible. But classical MRI findings are 5 findings. One is leptomeningeal enhancement. That is leptomeningealism. That is the meninges within the sylvian feature, as in the gyra and the sulci in between them. The covering of the brain is called as pachymeninges. The leptomeninges is the inside of the brain. Second is basal exudates. Third is hydrocephalus. Fourth is tuberculomas. And fifth is vasculitic infarcts. So we'll discuss all 5 imaging patterns. Basal exudates basically are thick exudates of contrast enhancement. We are commonly seen in intrapedunculair fossa, pontine cistern, ambient cistern, and suprasellar cistern. Now, there is a name given to this, a spider-leg appearance. I'll show you the image just a minute. So if you can see on the right side, now here the sylvian fissure, there are basal exudates. Even here in the interhemispheric fissure, there is a basal exudate. And near the pontine and the parapontine exudates, there are exudates in the scene, giving a spider-leg appearance. Flare image of the show of the simultaneously shows it is the hydrocephalus and the periventricular ooze. Hydrocephalus is the second imaging pattern which we commonly see in tuberculosis. Hydrocephalus is characterized by ventricular enlargement. Now, traditionally, what is described is Evans ratio, that is the maximum width of the frontal horns divided by the maximum width of the inner skull at the same level, and this should be more than 0.3, that is 30%. And the size of the fourth ventricle may be helping to differentiate the 2 types of hydrocephalus. One is fourth ventricle is enlarged in communicating hydrocephalus. It is normal in non-communicating hydrocephalus. Most commonly seen and most frequently encountered in clinical practice is tuberculomas. Tuberculomas on imaging may be discrete or coalescing. Their enhancement of contrast may be homogeneous or rim enhancement. However, important point to note is that the ball of the tuberculoma is irregular more often than not. There are 2 common types of tuberculoma: caseating with a liquid core and non-caseating tuberculomas. On MR spectroscopy, the tuberculomas show a classical lipid peak. Tubercular abscesses are also commonly seen. They are large, thin wall, multiloculated, and shows diffusion restriction. Now remember, diffusion restriction is basically because of the high protein content in the tubercular abscess. Anything which has a high protein content like your dermoid cyst, similarly, will have a diffusion restriction. Now, imaging pattern differentiating caseating, solid caseating, and a non-caseating. Now, solid caseating tuberculoma with a liquefied core, here the T1 will be hypointense, T2 will be hyperintense with a hypointense rim, and on post-contrast T1, there will be rim enhancement. A caseating but a solid granuloma, where T1 will be, the center is iso to hypointense, T2 will have a center of hypointense with an hyperintense rim, and post-contrast T1 image would show a rim enhancement. A non-caseating granuloma would be on T1 weighted image, it will be hypointense. On T2 weighted image, it will be hyperintense. On post-contrast T1 weighted image, there will be homogeneous enhancement. So if it is a caseating granuloma, there will be rim enhancement, or if it is a non-caseating granuloma, there will be homogeneous enhancement. Non-caseating granuloma will always have some overlap with neurocystic sarcosis, and that again it's itself a small lecture of differentiating tuberculoma and neurocystic sarcosis. Now coming to this imaging pattern. Now if you see on T2 image, there is a hypointense or hypo to isointense lesion with a surrounding hyperintense edema. On contrast, there is a rim enhancement with irregular coalescing multiple discrete as well as coalescing tuberculomas. And on the MR spectroscopy, there is a lipid peak. So this is a caseating granuloma with a solid core. Second image. Now, if you can appreciate, this is a hyperintense core. There is a hypointense rim surrounded by an edema. On diffusion, there is a restriction with corresponding ADC reversal on the ADC image, and there is a ring enhancement of the lesion. So this is a caseating granuloma with a liquefied core. Fifth pattern what we see in tuberculosis is vasculitic infarcts. They are classically seen in basal ganglia and the paraventricular, basically subcortical region. There is no mass effect. They are small, random, discrete infarcts. Along with neuroimaging, we often do the chest imaging because many a times we have a confusing picture. We don't have a diagnosis of tuberculosis. So so chest imaging, HRCT, will always aid to the diagnosis, or maybe we can get a lymph node or some opacities in the HRCT which are helping us in diagnosis. Coming to the treatment mainstay is antitubercular drugs, corticosteroids, and neurosurgery. Other part would be, I'll just briefly discuss on immunomodulator drugs, treatment of paradoxical tuberculosis, and a drug-resistant tuberculosis. AKT, these are all standard first-line AKT. We have to start as early as possible. There has been a clear-cut mortality benefit. Now, these are the classical things, HRZES, isoniazid, rifampicin, pyrazinamide, streptomycin, and ethambutol. The dose is, we all know this, 5 mg per kg per day for isoniazid, maximum is 300 mg. Rifampicin is 10 mg per kg per day, maximum is 600. Pyrazinamide is 25 mg per kg, maximum is 2000. Streptomycin is 20 mg per kg, maximum is 1000. Ethambutol is 15 mg per kg, maximum is 1600. Now, what is the regimen? The WHO and the Indian regimen is slightly different. The WHO says that the intensive phase should be of 2 months, containing of 4-drug ATT, which is the HRZS. The continuation phase should be HR only 2-drug ATT, and that is for 10 months. But the index guidelines for tuberculosis in India, this is specifically for extrapulmonary tuberculosis I'm talking about. The intensive phase should be 4 drugs, where instead of streptomycin, they prefer ethambutol, and that is for 2 months. 4 drugs for 2 months. The continuation phase for HRE, 3 drugs for 7 months. But this advisory, this guidelines is for extrapulmonary tuberculosis. The advisory committee for specifically for CNS tuberculosis, they extrapolated that pyrazinamide is better instead of ethambutol in continuation phase, and rather than 9 months of continuation phase, it is better for intensive phase to be of 3 months and continuation phase to be of 9 months. So total of 12 months of duration of tuberculosis. However, many a times there is a clinical dilemma and we have to continue AKT for uncertain period of months. But that are all isolated cases. For theory point of view, we just remember the guidelines, what we say, what we have discussed. Corticosteroids, you have to start as early as possible. These are the mainstay. Many a times we were asked what are the treatment of CNS tuberculosis. We said ATT with steroids, but our teacher said no, it is steroids with ATT rather than ATT with steroids. They one and the same, but steroids are very important. It reduces the meningeal inflammation, it reduces edema and the intracerebral pressure. If we are using dexamethasone 4 mg per kg per day, and at least to give for 2 to 4 weeks, and then taper gradually every 0.1 mg per kg weekly. Now, neurosurgery is mainly done for hydrocephalus. The timing of neurosurgery is not clearly defined. Worsening of GCS, that is not responding to ATT and steroids, is the time where you have to go for neurosurgery. Second is that if the patient directly presents with you on with stage 2 or stage 3 TBM with hydrocephalus, we have to intervene. A communicating hydrocephalus can be given a trial of ATT and steroids and can be waited, but unless the patient is deteriorating, we have to intervene. Now, what we do for neurosurgery, we do a hydrocephalus shunting, VP shunting, and an endoscopic third ventriculostomy. And EVD is done as a temporary measure. It's just a bridge where we have to buy some 6 to 12 hours until a definitive surgery is performed. Paradoxical tuberculosis. Now, this is quite commonly we are seeing. Initially, a few years ago, we are not common with this term. But now very rampantly we are seeing this tuberculosis. It is paradoxical TB. This is TB iris, that is immune reconstitution inflammatory syndrome. Now, what happens is that patient shows some improvement with tuberculosis, with ATT and steroids, but then there is worsening of pre-existing lesions or appearance of new lesions. The timing of developing a paradoxical reaction is around 4 weeks to 4 months. There is clinical as well as radiological worsening. The most common is the appearance of new tuberculomas, development of spinal arachnoiditis or optocosmetic arachnoiditis or hydrocephalus. The mechanism which is proposed is it is an exaggerated host immune response against the tuberculous antigen. The mainstay of treatment of paradoxical reaction is steroids. Now, here we give a prolonged course. We do a very slow taper of corticosteroids. There is no definitive guideline how to taper steroids, but what we commonly follow is they will taper 5 milligram every 15 to 20 days. Other drugs which are experimentally used are thalidomide. However, thalidomide has shown some good results in paradoxical reaction. Interferons have been used, adalimumab and minocycline. Drug-resistant tuberculosis. Now, this is we know that it is associated with poor outcome as well as CNS tuberculosis is bad. Drug resistance of CNS tuberculosis is even worse. There is increasing prevalence. We have to suspect when the patient is not responding to our first line of ATT, or the patient has a past history of multi-drug resistant tuberculosis. Drug sensitivity testing has to be done, and then the regimen has to be according to drug sensitivity test. But till the time we do get the drug sensitivity test, there are intensive phase and continuation phase. The intensive phase is for 6 months. The continuation phase is for 12 to 18 months. Now, the regimen is that one drug is to be selected injectable, apart from all the aminoglycosides, amikacin, streptomycin, kanamycin, caprimycin. One fluoroquinolone should be used, gatifloxacin, leoflox, moxifloxacin, and at least 3 out of the other active drugs, pyrazinamide and or ethambutol, cycloserine, ethinomide, linezolide, or clofazimine. Others are PAS, bedaquiline, this is the newer drug, imipenem, meropenem, and amoxiclav. They also have some anti-tubercular actions. Immunomodulator drugs and therapies. Now, there are only few case reports and small number of patients. Thalidomide has a good results in optocosmetic arachnoiditis and large tubercular abscesses. Adalimumab has shown some good response in paradoxical tuberculosis. Interferon gamma in tuberculomas which are not responding. And the role of prophylactic aspirin is debatable. Only it is used in when there is definitive vasculitic infarct. One more slide. HIV and CNS. Now, the association of HIV and CNS tuberculosis is around 10 to 20%. The most common presentation of CNS tuberculosis is meningitis, tuberculoma, or abscess. There is greater case fatality. Now, the debate is when to start ART along with the ATT. Now, if early initiation of ART leads to an iris cell-like syndrome, and delayed initiation of ART can cause you opportunistic infection. So, the suggested approach is that start ATT first, and ART can be reintroduced after 2 months. But in a patient with a severe immunosuppression where the CD4 count is less than 100, both the therapies can be started simultaneously. This is my last slide. Spinal tuberculosis. The spinal tuberculosis can have multiple involvements, as we discussed in that first slide of the classification. It can be a vertebral involvement, that is classical port spine, a tuberculoma, a spinal arachnoiditis, a TB myelitis with syrinx formation, or a tubercular abscess in the spine. Spinal cord and root involvement can be symptomatic, asymptomatic. Asymptomatic as in when the can have simultaneously CNS tuberculosis where the patient is having altered sensorium, and later when the patient improves, and then we realize that it was paraparesis also along with the altered sensorium. Spinal arachnoiditis can develop paradoxically while the patient is receiving ATT. Spinal involvement can have your UMN signs where it is a myelopathy like picture with the sphincter involvement, or a predominantly LMN sign where it is a lumbosacral arachnoiditis like picture. Neuroimaging shows diffuse root involvement, meningeal involvement, and cord with contrast enhancement. Now, this is the involvement of spinal tuberculosis, where you can see the destruction of the vertebrae, along with the involvement of the intervertebral disc, and there is paraspinal collection, if we can appreciate, around the paraspinal region, around the disc. Thank you. These are my references. Thank you very much.
Thank you, Dr. Mehta. Very comprehensive. I think you covered everything, and that too in a short time. Very nice. Let's move on to a second infection, cerebral malaria. Again, common in our part of the world, tropics, and we've chosen this, covering the mechanisms and treatment. Somehow, with with less and less cases, we are not reading cerebral malaria much, so that's why I chose this topic. So that way we could get our attention again. And I request Dr. Sakre to deliver his lecture after.
Good evening, and thank you for the opportunity. Just a second. Is the screen visible?
Yes.
Okay. So we'll be discussing.
You have to share it. It's not shared.
It is not shared.
No. Yes.
Thank you for the opportunity, and we'll be discussing mechanisms and treatment of cerebral malaria. This the scheme of presentation will be as seen here. As we all know, cerebral malaria is caused by infection by the protozoan of the genus Plasmodium. It is transmitted by the blood meal of an infected female mosquito of the Anopheles genus. Plasmodium falciparum is commonly the etiology, but even Plasmodium vivax and other species are known to cause severe cerebral malaria. Cerebral malaria carries a very high mortality and morbidity, around 20 to 25% in adults. And the neurological sequelae are more common in children and patients who present with severe disease. Coming to the definition, WHO defines a cerebral malaria in a patient who cannot localize a painful stimulus, that is a GCS of less than 11, or a postictal impairment of consciousness lasting for more than 1 hour. Also, he needs to have peripheral asexual Plasmodium falciparum parasitemia and has no other identifiable cause of encephalopathy. Practically speaking, any manifestation of cerebral dysfunction in a patient with malaria is considered and treated as cerebral malaria after ruling out the other causes. Briefly discussing the clinical features, generally the patient presents with 2 to 3 days history of preceding fever associated with chills and headache and myalgias. It is a diffuse symmetric encephalopathy which is characterized by a prominent absence of signs of meningeal irritation. Many neuroophthalmic signs like eye deviations, forced eye abductions are seen, bruxism, and sometimes prominent pout reflex is seen. Severe cases may show flexor or extensor posturing. Seizures are fairly common, more commonly seen in children, generally GTCS, and generally occurs in cluster. A very specific entity is malaria-specific retinopathy, commonly seen in endemic areas and is very useful and specific for diagnosis, characterized by retinal whitening, vessel changes, retinal hemorrhage, and papilledema. Now coming to the life cycle of the malarial parasite, the life cycle is takes place in two hosts, the human host and the mosquito. It is characterized by two phases, the exoerythrocytic phase and the erythrocytic phase. The exoerythrocytic phase starts when an infected mosquito pierces a person's skin to take a blood meal. The sporocytes which are present in the saliva of this mosquito enter the bloodstream and then migrate to liver, where they infect the hepatocytes, and then patient remains asymptomatic for a period of 8 to 30 days. During this potential dormant period in the liver, these organisms differentiate into thousands of merozoites, and once these merozoites infect the hepatocytes rupture, releasing the merozoites into the blood cells, and then they infect the RBCs. After infecting the RBCs, the erythrocytic phase of the cycle begins. Once the erythrocytes are infected, the parasites again multiply and periodically break out from the RBCs, resulting in the characteristic waves of fever associated with chills. And thus the amplification continues to occur. Uh, Once this is occurring, simultaneously the sexual cycle also goes on, and some gametocytes are produced, which are again ingested by a mosquito bite. These gametocytes mate in the gut of the mosquito, and from there sporocytes develop and then travel to the salivary glands of the mosquito, and then are again retransmitted during the next bite to the human host. Same thing is described here. Now coming to the pathogenic mechanisms. The knowledge of pathogenic mechanisms was elucidated through autopsy studies and through experimental cerebral malaria models. These experimental cerebral malaria models have been very useful in understanding of the pathogenesis, as well as have helped in developing adjunctive therapies and in research for vaccines. The experimental cerebral malaria models are generally achieved by infection of the susceptible mice with Plasmodium burgii species. The pathogenic mechanisms are based on three core things. One is the erythrocytic changes in the infected RBCs. Second is the endothelial dysfunction, and third are the host responses or immune activation. These three things occur simultaneously and lead to the classical manifestations of cerebral malaria. Coming to the exact mechanisms, these are the exact mechanisms. However, they do not occur in this chronology and in fact occur simultaneously in a given patient. The infected RBCs tend to bind to the erythrocytic protein C receptors and ICAM1, and this is facilitated by Plasmodium falciparum erythrocyte membrane protein 1, and hence the infections with Plasmodium falciparum are considered to be more severe and dangerous than that of other species. This is called cytoadherence, and this leads to localized endothelial activation, which causes increased release of extracellular vesicles and increased von Willebrand factor and tumor necrosis factor locally. This release from extracellular vesicles is important, as this has been a target and has been evaluated for potential adjunctive therapies. This activation of endothelial cells leads to microvascular thrombosis, which is further precipitated by rosetting and clumping of the infected RBCs. Also, it has been observed that the infected RBCs show reduced deformability, leading to further microvascular obstruction and reduction in oxygen and nutrient delivery. This is called sequestration, and this further worsens the pathology. Also, in addition to these mechanical changes, there is immune activation by the humoral component, especially the malarial toxin related macrophage activation and CD8 positive T cell activation. This further leads to increased inflammation and uncontrolled nitrous oxide production. This ultimately leads to breakdown of the blood-brain barrier. Once there is enhanced vascular inflammation and breakdown of blood-brain barrier and leakage, there is further restriction of venous blood efflux and venous blood flow, which gives rise to intracranial hypertension and brain edema, which can further cause brain herniation, brainstem compression, and respiratory arrest and death. In addition to these mechanisms, there are some interesting mechanisms which have been specifically noted in the malarial infections or cerebral malaria, one of which is immunometabolism. By immunometabolism, what we understand is that the metabolic status at the cellular level affects and constrains the cellular function. What has been observed that cells which are energy deficient or cells which have switched over to anaerobic glycolysis, they show lesser immune activation and and models of such organisms show less severe cerebral malaria. Also, what has been observed that models on high fat diet tend to show less severity of cerebral malaria. This has been an area of active interest and development. However, nothing concrete or no concrete recommendations have come out of it as of yet. Also, talking of mechanisms in cerebral malaria, innate immune memory and trained immunity are very important. what has been observed that in certain individuals, previous infections tend to offer a protective benefit or a kind of immune tolerance. These patients develop malarial infections or malaria. However, they do not develop severe malarial infections or do not go on to develop cerebral malaria. In addition to the effect of previous infections, age and epigenetic factors have been found to be at play. And this is an area for active evaluation, especially when it comes to vaccine. Now, coming to the last part, treatment. Treatment can be broadly divided into antimalarials, antimalarials in special situations, supportive treatments, and management of complications. This is the usual thing which we generally mention in our medicine papers. Here, we need to mention few of the typical malarial complications like acidosis, respiratory involvement, hepatic and renal derangement. And the last part is adjunctive therapies and vaccines. Though we don't have anything concrete on adjunctive therapies and vaccines as of now, at least a mention should be made that it is an area of ongoing research, especially CD8T activation modulation, extracellular receptor and vesicle modulations, and immunometabolism. Coming to the specific treatments, antimalarials. Artesunate is the drug of choice. It is given at the dose of 2.4 mg per kg body weight IV at time 0 or as soon as possible, followed by a dose at 12 and 24 hours. And once the patient can switch tolerate orally, it can be switched to oral treatment and has to be given and patient needs to complete a combination based therapy. These guidelines came when IV doxycycline was not available. That is why it emphasizes the oral aspect of it. But once IV doxycycline is available, we can even use it for combination therapy. The next drug recommended is quinine. Quinine is given at a loading dose of 20 mg per kg body weight as a dihydrochloride salt, slow IV over 4 hours, and then it is given 10 mg per kg every 8 hourly, and again it is given by slow infusion. The side effect profile of quinine is very characteristic, and one needs to monitor the ECG for rhythm disturbances, QTC prolongation. One needs to monitor sugars because it can cause hypoglycemia. It can cause severe dizziness, tinnitus, and local site reactions. So slightly toxic drug, but a very useful drug, and needs to be used. Also, generally it has to be used in combination, or once a patient can take orally, patient needs to be shifted on combination therapy. It is used in combination with doxycycline or clindamycin. Coming to special situations, whenever artemisinin resistance is suspected, quinine is the drug of choice. That is why we need to know the side effect profile, the dosing of quinine. Another use of quinine is malaria in pregnancy. For first trimester of pregnancy, quinine plus clindamycin is the drug of choice. And for second and third trimesters, artesunate plus clindamycin can be used. Coming to radical cure, especially radical cure is needed in patients who have Plasmodium vivax or oval infections. Radical cure consists of administering primaquine for 14 days at the dose of 15 mg per day. However, before administering primaquine, we need to confirm the G6PD status of the patient. Thank you.
So, as you can see, even with malaria, like tuberculosis, and now that we are all every day hearing about COVID, in addition to the virulence and the factors of the organism itself, body's own immunity, here in malaria, I think the surface molecules such as adhesion molecules are very important, and that's what Dr. Sapre has elaborated and explained to you very properly. So I would urge all PGs to be ready with such kinds of questions where they would ask specifically on how the tissue destruction, how the process of disease occurs within the nervous system. Like similar thing may appear for tuberculosis as well, for corona and other things. Yes, we'll move on to the next, another very important infection, neurocysticercosis. We've chosen only a small part of it as important as it is, which is critical evaluation of its treatment. However, remember, like Dr. Manan Mehta also said in his lecture, there can be one whole short note on differentiating between radiologically differentiation between neurocysticercosis versus tuberculoma. There could be radiology of cysty, there could be clinical features. And another question that I have seen is single ring enhancing lesion, its diagnosis and management. So there are several issues pertaining to this particular infection. We chose to address one. I thought it was very important because there are several presentations and each will have, in addition to the antimicrobial, will have a certain different approach, which Dr. Takarkar has very nicely handled. So off to him, Dr. Takarkar to start his lecture.
Yeah. Good evening, everybody. Shall I share the screen?
Yes, yes.
Good evening, everybody. I thank everyone for the opportunity given to me. So my topic is critical evaluation of treatment of neurocysticercosis. It's the most common infection causing epilepsy all over the world. It's the commonest cause of symptomatic epilepsy. So I will be covering it in mostly very briefly. Basic introduction of the NCC, its types and stages. After that, treatment according to the type and stages of NCC and complications. So neurocysticercosis, it's an infection of the CNS, as we all know, along with its meningeal coverings by the larva of Tinea solium. It's the commonest cause of symptomatic epilepsy all over the world, accounting for about 29% of the acquired epilepsy in adults. Though it is a very ancient disease known since Egyptian and Ayurvedic times, but it still has its controversies regarding its treatment. So, to make the decisions for the treatment, we should all know the classification of the neurocysticercosis according to its site and stages. So, according to the site, NCC can be parenchymal and it can be extraparenchymal. Parenchymal means where the NCC lodges into the substance of the brain, and then it goes into its 4 stages. And extraparenchymal can have some atypical presentation. It can lodge into intraventricular portion of the brain or subarachnoid spaces in the spinal cord or the retinal and optic nerve. That is the ocular NCC. So NCC passes through 4 stages: vesicular, colloidal, nodular or granular, and calcified. Of these, the vesicular and colloidal are considered as a viable NCC, and nodular is a degenerative form of neurocercosis, and calcified is the dormant form, as they say, of NCC. But still, there is a lot of controversy in the calcified NCC only. So, to differentiate on imaging, the vesicular form of NCC is a fluid-filled cavity with a scolex inside. The scolex is seen as like a centric dot sign, as we all can see on CT scan and T2 flare imaging of the MRI. Here we can see the clear space cystic lesion and one eccentric dot. This is the characteristic of vesicular form of neurocercosis. It's a viable form. And after this, the second form is colloidal. Colloidal is when the scolex disrupts the larval stage, the larva, which is the scolex. It degenerates into a gelatinous material, and that is, it forms into the colloid. So the part B is the colloid here. Second, this is the colloidal form of NCC. After the colloidal form, the further degeneration and anti-inflammatory mediators of our system attack the colloidal cyst, causing its degeneration, and it leads to a significant amount of edema around the lesion. This is the nodular or granular form of neurocercosis. So this is a dying NCC, and after the third stage, here comes the fourth, that is the calcified form of neurosurgery, where we can see just calcified T2 hypointense lesions. This is a T2 image. It can be more clearly seen on GRE and CT scans, where we can see tiny speckles of dots as a calcified NCC. So to give a proper treatment, we should all be familiar with the stages of NCC. We'll tell you how. So the first first type of NCC is parenchymal, and most commonly solitary intraparenchymal neurosurgery. Solitary form of NCC is the commonest form, which account for 60% of the total NCCs. Remaining 40% are multiple NCCs, where more than 2 or NCC can be found. So solitary intraparenchymal NCC can be classified into 2, viable and non-viable. So the viable are vesicular and colloidal. These are treated with antiepileptic drugs and steroids in presence of significant edema. Whether to give anti-epileptic drugs or not is still a controversial issue. But the recent guidelines by IDSA in 2017, they have recommended to give anti-epileptic drugs as a monotherapy for 14 days under the cover of steroids. And antiepileptic drugs are warranted to about 6 months to 2 years of duration. So the dosage of steroids is 1 mg per kg of prednisolone or 0.75 to 1.25 per kg of methylpred. And albendazole monotherapy can be given in a dose of 15 mg per kg. So this was for viable solitary intraparenchymal NCC. Non-viable, that is nodular or calcified cysts, have some other issues with them. Nodular form of neurosurgery is a dying cyst, so we don't need to give any anti-epileptic drugs in here. So the major treatment part of nodular NCC is steroids to reduce the edema around the cyst, thus improving the clinical condition of the patient and also decreasing the seizures. And the other antibiotic drugs have to be given in any form of NCC with seizures. That is the known, it is the given thing. So second most controversial part of the NCC is calcified neurosurgery, which can be a source of refractory epilepsy. Right. So most of the times, calcified NCC is easy to treat. We just give antiepileptics and steroids if there is some edema. If there is no edema, we don't need to give steroids. So when after giving steroid antiepileptics for six months or 1 year, if we repeat the imaging, most of the times calcified NCC also disappears from the imaging. After that, 6 months later, after the disappearance of the calcified lesion, we can stop the therapy of antiepileptic drugs. But around 20 to 25% of the calcified NCC do not resolve, and they remain as it is for years together, and they might become a source of refractory epilepsy later on in the life. So it has been seen quite frequently that calcified NCC can be linked with mesial temporal lobe sclerosis. Though this is there are so many hypotheses, but no one has proven it yet. Around 27% of the patients with refractory epilepsy in pre-surgical evaluation are observed to have solitary calcified granuloma, that is NCC. So in patients with refractory epilepsy with solitary calcified NCC, epilepsy surgery is indicated. So this is one part of calcified NCC where surgery is indicated. So in pre-surgical evaluation, EEG, video EEG, and MRIs, these are done in sequences, and so many times it has been found that mesial temporal lobe resection resolves the refractory epilepsy even if the solitary granuloma is not removed. So a trial was done with MTL versus MTL plus SCG resection, but still there was no significant evidence to confirm the fact that dissection of MTL, basal temporal lobe, and lesionectomy, that is the dissection of the solitary granuloma, is better than singular resection of the basal temporal lobe. So these problems is still controversial, and no substantial study has been published yet to resolve this. So the another question regarding solitary granuloma is, do anti-helminthics impact seizure outcome? So there is a one school of thought that after when there is solitary granuloma and we give anti-helminthics, it reduces the conversion of vesicular form of NCC into the calcified form, thus reducing the further production of seizures. But though there is a resolution of lesion with anti-helminthics and a reduction of seizures by 1/3, it is proven fact that anti-helminthics don't prevent the calcification of the cyst. So it can reduce the number of seizures, but it cannot prevent the calcification of cyst. So the other question regarding treatment of solitary granuloma is about optimal duration. So as I have already told, 6 months to 2 years is the optimal duration they have recommended by the IDSA in the recent 2017 guidelines. But this depends on individual person to person patient. So the other 40% form of NCC is multiple neurosurgery. When two or more than two cysts are found in the central nervous system, they are termed multiple. So NCC has its own controversy. Multiple NCCs are usually in various stages of their evolution. That is, some might be in vesicular, some might be in nodular, or some might be in calcified stages. So the treatment of every stage differs, and hence there are controversies in treating multiple NCCs. Few trials are focused on management of multiple NCCs, that is more than 20 cysts. Maximum trials are done on patients with 2 to 3 or 4, 5 to 6 or 10 multiple cysts, but very less trials are there which are focusing on more than 20 neurosurgery. So there are so there are no doubts in treatment of role of steroids and antiepileptics in management of these patients, because steroids are the mainstay of treatment of multiple NCCs, as they also have mortality benefit, and they also decrease the encephalitis stage of the patient, and also they decrease the syphilis. A trial by Garcia in 2014 compared the efficacy of standard albendazole treatment versus albendazole plus praziquantel and albendazole plus praziquantel alone and high dose albendazole. These were given for 10 days, and they have concluded that the combination therapy of praziquantel plus albendazole is better, but it should always be given in an adequate cover of steroids. So multiple NCCs can be treated only if they are given under adequate cover of steroids. Also, a study few studies have been done for the treatment of multiple NCC, where albendazole was given for 28 days, and 15 mg per kg singular cycle of albendazole was given for 28 days, and it also led to reduction in lesion load. But no study has been published which will directly links the decrease in seizure recurrence with albendazole. So, multiple NCC, steroids and antiepileptics are mainstay of treatment. Albendazole or praziquantel can be given according to the individual patient. So, so now we are turning to let's turn toward extraparenchymal NCCs. The most subarachnoid NCC is a most unusual form of neurosurgery, which is where the NCC surface is lodges into subarachnoid space. And aberrantly proliferates into a large mass. It is most difficult to diagnose, and many a time patient remains undiagnosed till the NCC grows to a very big size, causing mass effects, arachnoiditis, or the hydrocephalus. So as the cyst increases in size, proliferates, their antigen load increases, and it causes massive arachnoiditis and causing hydrocephalus. So immunosuppression is very important, and long-term anti-helminthics are needed in treatment of subarachnoid NCC. So The many trials treating subarachnoid NCCs have shown that long-term albendazole, that is 15 mg per kg for more than 30 days in multiple cycles, have been proven to be effective in treating subarachnoid NCCs. Antiepileptics should always be given in cover of steroids, but in case of complicated subarachnoid NCCs where there is a massive hydrocephalus or mass effect, surgery is indicated. So neurosurgical options like endoscopic removal of the subarachnoid cyst, BP shunting or debulking are of choice where there is significant compressive effect, mass effects of the NCC. Second, extraparenchymal NCCs are intraventricular. They are around 10 to 20%, mostly found in multiple NCCs. Some are spread to parenchyma and some into the intraventricular spaces. So these are primarily symptoms are caused primarily because of complete, partial, or transient obstruction of the CSF flow caused by the migrating cysts and associated ventriculitis. So on a test, this may cause acute or episodic symptoms of transient obstruction as seen in colloidal cyst tumors, as we see. So it can present acutely as well as chronically. And recommended treatment in ventricular NCC, intraventricular NCC is surgical. There is no role of antiepileptic drugs in intraventricular NCC, and even there's somewhat role of steroids in ventriculitis. So surgical removal of cysts endoscopically or through craniotomy has been demonstrated well according to the individual cases, and these have provided excellent results. BP shunting is invariably done in every case of hydrocephalus with intraventricular NCC. So in some few cases, cyst fenestration has also been useful where removal was not possible, and complications of surgical treatment are ventriculitis, valvular cyst, or shunt failure. So in these cases, steroids are the mainstay of treatment to cover it. So the third extraclinical form of NCC is spinal. It is very uncommon, 1.5 to 14% of NCCs, and two types are most common. Two types are considered: leptomeningeal and intramedullary. So leptomeningeal NCC is more prevalent than intramedullary. Intramedullary is most symptomatic. It is rare, but it is most symptomatic. It occurs through hematogenous and transventricular migration, and cysts are commonly found at dorsal anal cord, which is also the common state of tubercular pot spine, that is. So spinal NCC corticosteroids again is treatment of choice in acute symptomatic spinal NCC where patient present with paraparesis due to the edema produced around the spinal Tuberculosis. And along with that, medical therapy is indicated, and it has been given and it has been found to be successful in treating spinal NCC. Though surgical management is also indicated, but so the many trials have been performed comparing surgical management versus the medical. It has found that medical is somewhat superior to surgical management of NCC. So in cases where the size of NCC is huge, causing a mass effect, excision of the cyst is recommended. So in case of severe arachnoiditis, even that is also not possible, or very medical management is again preferred in such cases. So post-operatively, it is recommended to treat patients with antiepileptic drugs, and follow-up imaging has to be done every 6 monthly after if the cyst removal was very difficult. Fourth form of NCC is another rare form. It is only seen in 1 to 3%. It can be a vitreous NCC or subretinal or retinal NCC. So occur a dying cysticercus cyst incites a severe inflammatory response due to leakage of toxins from the perforations present in the cyst wall, leading to sudden loss of vision. So anti-emetic therapy is never indicated in patients with vitreous NCC or subretinal NCC. Most of the times, ocular cysticercosis is always associated with multiple NCCs. That is in the intraparenchymal NCC, and along with it, there is ocular NCC. So while treating for the multiple NCCs, we should always look for whether there are any cysticercal cyst in the eyes, that is in the retina or in the vitreous. So if we treat the patient without looking into the orbit, the patient might lose the eye. So So it is always advised to load ocular cirrhosis when antiparasite treatment is planned. Past vitrectomy or cyst removal using further techniques are advised surgeries in these cases. So coming to the complications, hydrocephalus, as I have already told you, it's VP shunting and removal of the interventricular subarachnoid NCC are the commonest they give rise to resolution of the hydrocephalus. Along with it, even multiple NCCs without subarachnoid NCC have also been proven to have hydrocephalus, which is a non-obstructive hydrocephalus and it is chronic. So such hydrocephalus do not need to be treated as such. Only a chronic hydrocephalus with subarachnoid and IV NCC need to be shunted. Other commonest complication of multiple NCC is cervical encephalitis. So in encephalitis, antiherpin drugs are contraindicated. High dose steroids and antiepileptics are treatment of choice. And the patient have been taking high dose steroids for a long duration of period and they don't get improved. So this is the most worst form of cervical encephalitis and it is life threatening. Third commonest complication is refractory epilepsy, which we already have discussed. Multiple calcified NCC, there is no definitive treatment. Only antiepileptics have to be given and steroids needs to be given. And calcified cannuloma surgery can be attempted. Mostly major temporal dissection along with regenectomy is the best thing to do in calcified cannuloma with refractory epilepsy. Many a times multiple NCCs or solitary granulomas have been commonly seen in progressive cognitive decline, that is in patient with dementia, but there is no clear-cut treatment for this as such. So summarizing, anti-epileptic treatment whenever to be given should be under corticosteroids. It is absolutely contraindicated in cervical encephalitis. Surgery is a treatment of choice in interventricular and ocular NEUROSURGERY. In multiple and subarachnoid NCCs, long-term anti-epileptic treatment is needed. That is, you might need to give many cycles of albendazole or a combination of albendazole plus praziquantel and steroids to treat such patients. And still, they are very difficult to treat. Treatment should be individualized in spinal and subarachnoid NCCs, whether to go for medical or surgical management. And a surgical intervention may be of benefit in patients of solitary calcified granulomas with refractory epilepsy, as I've told, that a lesionectomy with mesial temporal dissection can be a way forward in such cases of solitary granulomas with refractory epilepsy. So I have taken this mostly from the clinical infection disease IDSA, and rest I have written here. You can have reference from these articles for NCC. Thank you.
Thank you, Dr. Takalkar. Very thorough that was. And you classified and addressed each and every aspect very well. That was very useful. Great. Let's move on to our last lecture. Obviously, after bacterial tuberculosis and parasitic infections, the session cannot get over without addressing viral encephalitis. There have been several questions on individual encephalitis as well, like dengue, chikungunya, herpes. Here we've chosen the broad generic title, viral encephalitis in India. And I hand over the session to Dr. Rahul Kulkarni, who has done a lot of work in this area. I hope many of you know him as an eminent neurologist from Pune. I request him to deliver.
Thank you. Okay, can you see my screen?
Yes.
All right. So thank you. I'll be talking about viral encephalitis syndromes in India. So basically, we know that many times when the patient, the diagnosis is made as acute meningoencephalitis, this is usually not a good term because we know that here you're looking at probably two different disorders. There is either a meningitis or an encephalitis, and obviously meningitis is caused because of bacterial infection, while encephalitis is caused because of a viral infection. So you have to break a patient when it comes to you between either a meningitic syndrome or an encephalitic syndrome, because the management, investigations, as well as the prognosis is going to be different. At times, it is difficult to differentiate between these two things, meningitis versus encephalitis, but then one can use clues which can come from clinical clues, CSF clues, as well as radiological clues to differentiate between these. What are the clues in clinical clues? We know that meningitis is usually associated with meningeal signs. By meningeal signs, we know that patient has headache, vomiting, photophobia, neck stiffness, as well as sometimes cranial nerve involvement, if the nerves which are at the base of the brain. As well as in the patient of encephalitis, there are cerebral signs, signs to suggest that there is involvement of the brain tissue. Those signs would include altered sensorium, there may be focal deficit, and there can be seizures. Of course, there can be overlap between various syndromes, because if you have a meningitis, there is always some inflammation or edema of the surrounding brain tissue. So patient may have some encephalitic component into it. While in an encephalitic patient, there may be some inflammation, or maybe there is sometimes some meningeal involvement is seen. But predominantly, if you have an encephalitic syndrome, you have predominantly signs related to brain involvement, while a patient who has meningitis will have predominantly signs of meningeal involvement. Of course, the CSF would also help us to differentiate between a bacterial disease as well as a viral disease. And I don't want to tell you about this two things that one has to see in a patient to differentiate between bacterial versus viral disease. You look at glucose as well as you look at WBC count. Other things that can use is C-reactive protein level. You can look at CSF lactate level also as one of the signs to differentiate between bacterial and viral disease. And of course, you can use radiological clues to differentiate whether it is a meningitic disease or an encephalitic disease when there is involvement of the brain parenchyma. And of course, we'll be talking about MR little later as well. So if you have viral encephalitis, how do you approach this patient? Of course, you take the history and decide what kind of disease he is. So when do you suspect that patient has got acute viral encephalitis or acute encephalitic syndrome, as it is called in India many times? If the patient has got acute onset disease with fever, as well as change in the mental status to suggest that there is encephalopathy and or associated new onset seizures. There is a criteria which has been given in 2014, which says that if you have an acute encephalitic syndrome, there is a major criteria which said that there is altered mental status for more than 24 hours with no other explanation. So patient doesn't have low glucose, he doesn't have low sodium, he doesn't have ongoing seizure activity as a non-convulsive status. And of course, there are minor criteria. You have to have at least two of these minor criteria. That patient has fever, patient has generalized or partial seizures, which cannot be explained because of prior seizure disorder, new onset focal neurological findings, patient may have CSF cells in the CSF, brain imaging showing some abnormality, and the EEG showing some focal abnormality. So if the patient has two of these minor signs, minor criteria, then you can say that patient has encephalitis. He or she should have one major criteria as well as two minor criteria. And then one has to differentiate from the routine disease that many times students as well as consultant would see in emergency or in ICU, which is called as encephalopathy or delirium or acute confusional state, which is usually associated with abnormal metabolic factors, sepsis, etc. So one has to differentiate the encephalopathy from the encephalitis. And we all know how to differentiate between these two. Patient of encephalopathy will not have headache, they will not have fever, they may have steady, of course, unless it is a septic encephalopathy. The mentation will be gradually deteriorating in patient of encephalopathy unless they throw a seizure, then there will be rapid deterioration. While in encephalitis, there may be some fluctuations in the signs. Focal signs will not occur in encephalopathy except probably hypoglycemia as well as hyperglycemia. The seizures are generalized seizures. The CSF is will not show abnormal cells. The EEG will just show diffuse slowing, and the MRI is often normal in encephalopathy. While in encephalitis, these things will be abnormal. So usually, physicians will not be aware of this, but the neurologists as well as neurology students will well know how to differentiate between encephalopathy and encephalitis. So if you have a patient where you think that he or she is suffering from encephalitis, then you are looking at the causes. In India, the causes would vary. Of course, the causes would vary from worldwide. In India, the commonest causes which are causing encephalitis may come as different episodes of epidemics. We know that there are epidemics caused because of JE in 60s and 70s and 80s and 90s, dengue, which is ongoing probably epidemic, chikungunya about 15 years back, West Nile fever, which was there for a few years back, KFD, which was there again few years back in a pocket in Karnataka. Chandipura caused an encephalitic syndrome as an epidemic maybe 20 years back. And of course, we now know that we are also at present not just in an epidemic but a pandemic which is ongoing for last 1 year or so. Sporadic encephalitis is caused because of herpes, the commonest cause. In India, dengue as well as Japanese encephalitis are still the causes of sporadic encephalitis. So the viruses have become so prevalent in India that anyone can get these viral infections. So arboviruses are not uncommon causes of sporadic viral encephalitis in India. Of course, mumps can cause an encephalitis, varicella zoster or enteroviruses. Rabies also can cause an encephalitic syndrome, which we all know. And again, I'll be talking about some of these viruses in little detail little later. So in India, it started with Japanese encephalitis. The first reports of encephalitis in India were all from Japanese, but then thereafter there are various viruses which have been reported from India. And then it was thought that till probably 2010, it was thought that if you have an encephalitis in India, then it has to be a Japanese encephalitis. But we know that the landscape is changing. And this was a review published a few years back, which clearly showed that in India, the viruses nowadays which are predominantly reported are non-JE viruses. And again, I'll show you an important study which was published from India, where they showed that none of the patients in the study actually had JE virus encephalitis. We often see encephalitic syndromes in our part of world. And if you ask me how many JE I would have seen in 20 years, probably 2 or 3. So it indeed is changing, and we are seeing lesser and lesser JE encephalitis in India. The landscape is definitely changing. So if you have a patient who has viral encephalitis, you will ask history, which season the patient has the encephalitis, whether he or she has traveled. If you have traveled, you will get some exotic viral encephalitic syndromes, typically the arboviruses, which would come from Far East or maybe from African countries or maybe even Latin American countries. If the patient has been bitten by any other mammal, then usually one would suspect rabies. If you have an immunocompromised host, then you look at different sets of viruses like cytomegaloviruses or maybe even varicella zoster viruses. And geographical location, which part of the world patient is staying or which part of the India patient is staying, one would think of different viruses depending on which virus is prevalent in certain part of world. So if you see the world map, in India, the commonest viruses that have been seen as far as the map is concerned are JE as well as West Nile, 2 viruses. JE is from India, it always go to the eastern side, and West Nile would go from India to the western side right up to the US. So India is the only country, remember, India is the only country where you will get both JE as well as West Nile. Otherwise, in the rest of the world, you will either get JE or you will get West Nile. But India is the only country where you can get either JE or West Nile. Remember that. Same map again shown here. You have dengue, which is everywhere in the world. Probably if you see in the tropical area, it is there everywhere in the world. You don't get these 2 viruses, the Zika virus as well as yellow fever virus, not in India or not in Asia, but you have these 2 viruses in India. So again, here you see India, you have both JE as well as West Nile. West Nile is probably far, far more. It is involving the entire US. You see it in Africa. You see in a large part of Europe, while JE is predominantly in the East Asia. In Australia, still you have West Nile. And in India, if you see, there are various areas which are endemic for various viruses. So you have the Nipah virus, which is there in Siliguri and certain part of West Bengal. We have JE, which is predominantly in Bihar as well as UP. Certain pockets of JE are also seen in Tamil Nadu. The Chandipura virus is predominantly in the central India, and there are some reports from Gujarat also, but predominantly Maharashtra, Karnataka, Telangana, this area. And then enterovirus are being reported from UP. And then we also know about the lychee virus. Again, I'll be talking about this, which has been reported from Bihar. This is if the patient is coming from certain part of India, you know which virus you're looking at, if you know these kind of maps of India. So if you have clinical signs, what signs you look? You see for rashes. If there is a rash, suspect measles as well as enteroviruses. If the patient has got glands, then you would suspect HIV or Epstein-Barr. If the patient has got parotid swelling, or if he or she has got, swelling of the testes, then you would suspect mumps, of course, as an infection. Neurologically, usually they will have signs of cerebral involvement in the form of altered mentation. They may have behavioral abnormalities. They may have seizures. There are certain viruses which are predominantly involving certain parts of brain. So the signs may vary accordingly. So if you have resistant seizures, if the patient is in status, it is far, far more common with HSV than with the arboviruses. If the patient has got Parkinsonian features because of involvement of the basal ganglia, we know that it is usually because of JE or West Nile. If the patient has got behavioral abnormalities going towards something like a Kluwer-Bucy syndrome, you would suspect HSV. If the patient has got brainstem signs, it may be seen in rabies. If there are cerebellar signs, they are seen in varicella zoster as well as Epstein-Barr. And if the patient has got a quadriparesis, which is because of the involvement of the spinal cord and maybe involvement of the anterior horns, and in certain cases it may be because of GBS-like syndromes. It may be because of JE, it may be because of cytomegalo, because of involvement of the conus cauda. Varicella zoster can cause similar syndrome, and rarely West Nile can also cause similar syndrome. So this was a paper which was published 3 years back. Large number of patients, 3,088 patients. They showed that fever was seen in 85%, alternmentation was seen in 63%, seizures were seen in 51%, headache in 33%, vomiting in 21%, and abdominal pain in 77%. So the predominant feature again in this series was fever, alternmentation, and about half of the patient had seizures. You see that headache and vomiting, which are predominant signs of meningeal involvement, are seen in only 1/3 to 1/5 patient of encephalitic disorder. So they are not common signs as far as encephalitis is concerned. So there are certain clues which can help us to differentiate between herpes versus non-herpes encephalitis. Of course, this is not probably a very good paper published in New England Journal about 2 years back. Again, not probably a very good idea to differentiate between. Anyway, most of the patient, if you have a sporadic encephalitis, one would start him or her on acyclovir. But it is worthwhile knowing this paper. If you have older people, acute presentation, fever at onset, maybe GI symptoms, less of ataxia. I don't know how to take ataxia as a part of encephalitis, and less rash, then one would suspect encephalitis because of herpes. But if the patient is younger, of course, children, usually you would rarely get herpes. You would more think in India, especially more of Japanese or similar viruses. Acute presentation is always in herpes. If you have patient presentation which is little slow progressive, one would not think of herpes. Probably you would think of autoimmune or similar disorder. Fever is again common in herpes. Remember that this is one of the important sign to differentiate. Fever would always be one of the signs. So there are in fact some reported patients where patients were worked up for PU and then they were found to have herpes encephalitis. So fever can be a common presentation of HSV. CSF, of course, we know in viral encephalitis, CSF would just help us to differentiate, confirm the diagnosis. It would show normal or increased proteins. The glucose is normal. The cells are there, which are lymphocytes, and the usual stains which are done for bacterial infections are not positive in these patients. So cells are predominantly lymphocytes as far as viral disorders are concerned. But if there are certain situations where there are no cells in the CSF, if the CSF is not seen immediately, you do the CSF on Friday, you keep it in the fridge, the microbiologist or the pathologist is not there for 2 days, they open the sample on Monday, all the cells are decayed and you don't see any cells. So delayed analysis, if there is alternative diagnosis, if you're looking at certain other disorders which look like encephalitis, like edem, then probably there are no cells. In herpes, if it is done too early, you won't get cells. And in immunocompromised, remember, you may not get cells. So if suspecting viral encephalitis and if the patient is HIV positive, you may not get cells in these patients. Very, very high number of cells, 2,000, 5,000, may be seen with mumps. Neutrophils, not a common presentation. Of course, we know that it is seen in bacterial, sometimes in edem, but certain viruses like enteroviruses or echoviruses can also get neutrophils in the CSF. Amoebic meningoencephalitis may have cells which are neutrophils. And low sugar again is a not common presentation of viral disorder, but it can rarely occur with mumps. It can occur with LCMV virus, and in the late stage of HSV, rarely one can get low sugar. So low glucose can occur in some of these disorders. But if you have low glucose, of course, you would think of TB as well as bacterial infection of central nervous system. Earlier days, we used to do antibody testing as far as diagnosis is concerned, but these are older tests, not useful. In India, they are still used for other viruses like JE, dengue, chikungunya, West Nile, cytomegalo, but not usually nowadays used for the herpes virus. It is predominantly for the arboviruses for which antibody testing can still be used. For herpes viruses, what we use is PCR, and PCR, of course, is a gold standard for diagnosis. It has also been tried for arboviral encephalitis, but problem is that the tests are not very standardized for dengue or JE, or they are not available freely, or even for chikungunya, it has not been available freely. You can also do throat swab examination for H1N1 as well as for the COVID. You can do stool examination for the enteroviruses. You can also do saliva examination or the skin clip examination for rabies virus. So other PCR can also be looked into other tissues of the body or body fluids for the diagnosis of certain viral disorders. They may not be seen in all CSF. And then we know that we have these multiplex PCRs which have been available, where you dip the one drop and then you can look at multiple organisms in the same sample. The disadvantages of this kind of PCRs is that the same set of PCRs are used everywhere in the world. In India, the sets do not have JE, they don't have chikungunya, they don't have dengue, which are the common causes of encephalitis in India. These are not there in the set that you have. And the set, if you see, there is herpes, there is Epstein-Barr, there is varicella zoster, there is a virus which is called as hantavirus, which I don't think any one of us has seen. So we need different kind of panels in India, which unfortunately are not being made available till date. The data shows that the sensitivity of these panels, multiplex PCRs, is 86 to 100%, and the specificity is more than 95% in 99% in USA. However, we do not have any data, significant data from India. So we really don't know what is the use of this kind of multiplex PCR. I usually don't use it in my practice. Imaging, of course, is an important tool for diagnosis of encephalitis syndrome. MRI is definitely superior than CT. It can be normal in early stages, and certain patterns on MRI help us to differentiate certain viruses. So if you have involvement of predominantly the temporal lobe as well as the limbic system, you would think of herpes simplex virus. If you have involvement of the thalami or the bilateral basal ganglia, you would think of Japanese encephalitis. If you have involvement of the brainstem, especially sign like this, where there is involvement of the pons in the dorsal part of the pons, this is a very common feature that we are seen in rabies virus. This is called as step sign, as we call it. If you have involvement of the corpus callosum, this can be seen in multiple disorders. Of course, we have seen this with dengue, but this has also been described with leptospira and many other viral disorders. If you have multiple dots which look like infarcts which are seen on diffusion, this is the feature of chikungunya that we had seen for the first time in the world. This has also been seen with Nipah virus and is also been found nowadays in Zika virus. And if you have predominantly bilateral thalamic lesion which appear little necrosed, this is a syndrome. These patients also have additional pontine involvement as well as cerebellar involvement. This is a typical syndrome of acute necrotizing encephalopathy. It is described with H1N1 or influenza. We have also seen this with COVID. We had also seen with dengue. So this is again a different pattern which is called as ANE, acute necrotizing encephalitis pattern. It is seen with various disorders. So this is a kind of table that one can remember about the imaging patterns of various viral encephalitis. This is probably pertaining to India. There are of course some viruses which are not common in India. Ebola and Zika are also there. But remember this table. If you have involvement of temporal lobe as well as limbic system, suspect HSV1, HHV6 if the patient is immunocompromised, and of course you can have immune-mediated encephalitis syndromes also. If you have involvement of the bilateral basal ganglia as well as thalamus, suspect JE, West Nile, dengue, also influenza, and now we can have COVID also in part of this. If you have involvement of cerebellum, suspect varicella zoster, Epstein-Barr. You can also get it with dengue, malaria, influenza, and paraneoplastic cerebellar degeneration. If you have involvement of corpus callosum, the commonest feature that we have seen is with dengue. It has also been described with influenza and leptospira. If you have involvement of brainstem, suspect rabies. It can also occur with listeria, again not a viral infection, but it can also be seen with enterovirus 71, JE, West Nile, and sometimes with dengue also. And if you have diffusion-mediated lesions, as I said, they are seen with chikungunya, Nipah, also seen with Ebola virus and Zika virus. If you have infarcts, usually it would be seen in varicella zoster, sometimes also seen with Chandipura virus. Again, a very peculiar feature that was described from India, Chandipura virus was presented with infarct. And if you have white matter lesions, we know that of course they are seen with PML, but they can also be seen sometimes with CMV. So if you have some tables like this, these are local image table, they will be helpful to differentiate between various viruses. So treatment wise, we know that the commonest virus causing encephalitis is HSV1, and it is a medically treatable. So in all sporadic encephalitis syndrome, it is worthwhile starting empirical acyclovir. Supportive treatment is required in many of the other non-herpes virus patients, where you have to look at hemodynamics as well as airway care of the patient, treat the seizures, treat the raised intracranial pressure. Sometimes if the patient has got large lesions involving herpes, you can also do decompression craniotomy, as like you do in large MCA infarcts or even in venous sinus thrombosis. You can also do decompression craniotomy in certain patients of HSV1. we call this as malignant herpes simplex virus encephalitis. So treatment, we know that IV acyclovir 10 milligram per kilogram for 2 to 3 weeks. There were some trials which were done with higher doses, thinking that in immunocompromised or in malignant disorders or serious disorder, 15 milligram may be useful. The trials have failed. The dose is 10 milligram per kilogram, usually 2 to 3 weeks. Same dose is also used for varicella zoster. For cytomegalo, you use ganciclovir or foscarnet. Same drugs are also used for treatment of HHV6. HIV we treat with ART, and there is no treatment for the common viruses that are seen in India, the arboviruses as well as enteroviruses. So this is a big block still for us, that last 50 years we are getting JE virus in India. Last 30 years we are getting dengue in India. Last 20 years, 15 years we are getting chikungunya virus in India. But still there is no treatment for these viruses in India. And remember that there is no benefit giving steroids, interferons, IVIG, oral minocycline. These are various drugs which have been tried worldwide. Every year you hear a new trial. All these drugs have failed. The predictors for poor outcome are presence of immunocompromised host, of course, GCS which is poor, of course, need to admission in ICU, of course, and elderly, of course. So if you have an old man who presents with poor GCS, he goes to ICU straight away, and if the patient is immunocompromised, then the outcome is going to be bad. Remember that the outcome is also bad if you don't treat them early. So this was another paper which was published about 15 years back, that they looked at patients of HSV1 and they found out what are the outcomes of the poor outcomes, poor prognostic factors in HSV1 patient. And they found that there are two factors which were independently associated with poor outcome. One was Apache score, which is more than 27, which is usually a bad score in any patient who goes to ICU. But the second factor which was important was if you don't treat them early, if you don't treat them within 12 hours after admission, the prognosis is bad. So early administration of antiviral drugs is the only parameter that as a doctor we can do to improve the outcome of the patient of herpes simplex encephalitis. So something like door to needle time, there is door to antibiotic time, and there is door to antiviral time. So the importance of time should be remembered for CNS infection, which sometimes can be emergencies. And in India, we know that viral encephalitis is an unresolved issue. If you have a sporadic encephalitis, you have herpes maybe in 10%, 8 to 10% may have JE, dengue maybe in some of these patients. So large number of patients, we don't know what is the cause. Enterovirus is considered to be one of the major cause in remaining the 70 or 80% of the patient. We don't know what is the best cause. And if you see this paper, which I quoted earlier, they had 3,088 patients. They could find out etiology only in 22% of the patient. So large 80% of the patient, they could not find out any cause. And the commonest cause in their series was herpes, 36% of these 22%, Epstein-Barr, 24%, varicella zoster, 13%, cytomegalo, 9%. So they had about 70 or 80% all herpes viruses. They found enterovirus in 4%. You see dengue, 3%, JE 0%, West Nile 0%. The commonest viruses which have been described in India, JE 0% in this series. Dengue, again a very common infection which can cause encephalitic syndrome, 3% of the patient. Retrovirus, 84% of the 0.84, so 1%. So this was a series where they found that the commonest viruses in India actually are the herpes viruses, which are all treatable viruses. HSV, VZV, CMV, treatable viruses. Well, the non-treatable virus is very, very uncommon in this series. This is, of course, from one part of India, 3 years back, Journal of Medical Microbiology. But we can clearly know that the pattern is changing in India. And again, 80%, we don't know the cause. It is only in 22% that we know the cause. So unfortunately, this is a problem in India, that the issue is unresolved. And then there are papers which have been from South India as well as from the North India, where they show that enterovirus can be an important cause of viral encephalitis in India. So there are probably certain viruses. We don't know how to look for enteroviruses. You can't do the PCR of enterovirus in the CSF. Stool PCR is the only test which is used. And again, stool PCR may be positive in many people. We don't know whether it is really cause and effect or it is just an incidental finding. So that's an unresolved issue in India. And of course, we know that this issue continues. In Bihar also, we had this issue. Cases of encephalitic syndromes were described from 1990s. Every year, there were more than 100 deaths, usually children, rainy seasons. They did lots of tests and everything came up negative. And we know that the cause nowadays is described is lychee. and it is actually not a viral encephalitis syndrome. It is a disease because of lychee. What does lychee cause? This area has been the largest lychee cultivation area of India. Lychee contains substance which is called as hypoglycine A, which is a toxin. When the children consume this lychee at night, they usually skip the meal. It is usually people from poor socioeconomic status. They just take lychee and they sleep. They don't eat their meal, and then hypoglycine causes hypoglycemia, and that leads to hypoglycemic encephalopathy. Because the diagnosis is not done, many of these children had died. So the cause of death here was hypoglycemia and not any viral encephalitis, which was thought to be. So the treatment is simple, just give them a lot of glucose. And then, of course, every 2-3 years, we hear new exotic viruses. Many of these are transferred to human from animals. They either come from Africa or from Eastern Asia. And we know that we are in the endemic, in the pandemic, which is ongoing for last 1 year because of COVID. Chikungunya was seen in 10-15 years back. It came from Africa. It does cause a lot of encephalitis, and we describe a lot of viral encephalitis because of chikungunya. Nipah virus causes encephalitic syndrome. It is seen in Eastern Asia. It is also seen in eastern part of India, and it is almost become endemic in certain eastern part of India. Ebola virus encephalitis is rare. It is not seen in India. Zika virus causes congenital Zika syndrome, which is type of encephalitic syndrome. It doesn't, and of course it causes GBS. It is not seen in India. It is seen predominantly in Latin America and also in certain part of North America. And COVID, there are cases of encephalitis which have been reported. There are few cases. These cases look like the influenza case that I showed you. So it presents with predominantly bilateral thalamic and basal ganglion involvement. There is some variable involvement of the cerebellum as well as pons. So it presents with the syndrome of acute necrotizing encephalitis, the COVID infection. And then, of course, there are other non-viral disorders which can also present with encephalitic syndromes like rickettsia, like autoimmune viral disorders, cerebral malaria, as well as listeria. They can also present with encephalitic syndromes. But of course, we are not talking about non-viral encephalitic syndromes here at present. And the list of encephalitic syndromes is big. There are, as I said, bacterial as well as fungal as well as parasitic disorders which can present with encephalitic syndrome, which I am not talking today. So the pattern recognition, there are various patterns which can be used. One can look at whether the viral encephalitis is sporadic, whether it is epidemic or it is endemic, and it would vary from the geographic areas. In India, again, as I said, the endemic as well as epidemic viral encephalitic syndrome is known. Epidemics can come because of dengue, chikungunya, West Nile, Nipah, Chandipura, and we don't know. Corona, of course, is going on as an epidemic. We don't know what next comes to us. And then the endemic viruses, JE has become an endemic. It initially came as epidemic, but now it has become an endemic part of India. Same as with dengue, enterovirus and rabies virus. These are viruses which are here to stay for a very, very long period. Of course, the other way to differentiate the pattern is see whether it is an isolated encephalitic syndrome or whether there is associated systemic involvement. The commonest typical viruses like herpes, like JE, they don't cause involvement of other systems, while dengue is known to cause involvement of the other system. So the chikungunya is known to cause involvement of the other system. So if you have involvement of the other system, other systemic involvement like low platelets, hepatic dysfunction, renal dysfunction, then we call some of these as tropical illnesses with meningoencephalitis. And the big three causes in India are dengue, rickettsia, leptospira. One can also add chikungunya as part of this. These are big three as far as meningoencephalitic syndromes with tropical illnesses. And then the third pattern recognition, as I said, is you look at the MRI picture and decide from the MRI whether you know what pattern you are looking in these patients. And then this pattern recognition with whether it is sporadic, whether it is epidemic or endemic, whether it is isolated or whether it is associated with certain disorders, or whether there is some MRI pattern that can be there, it helps us to differentiate between various viruses, because unfortunately the virological backup may not be present or may not be there everywhere for us. And this is one paper which is from Alan Rupert in 2018, New England Journal. Those who are interested in acute viral encephalitis, I would recommend them to read this. This is a very good paper. Rupert has written this paper. Thank you very much. Thank you.
So as you can see, such an elaborative topic as it has appeared as a short note, and you need to plan your answer very well by making use of several such points to discuss your answer and show how the kind of work that you put into words, how you translated into an answer and express your knowledge properly. Before I forget, we have a class this Thursday as a long case on demyelination, and the case will be taken by Dr. Ichapuria, a neurologist from Pune. And again, I come back to the same thoughts that I was carrying in my mind about addressing each and every infection in a different way. You heard the last lecture of Dr. Kulkarni. So many aspects that you can bring in. And as I said, I had chosen this as a broad topic, and there were already questions come up on individual infections, dengue, chikungunya, herpes. So be prepared for them. And then going back to the previous lectures, as you can see, Dr. Mehta highlighting the importance, sensitivity, specificity of each of the tests, the classic MRI features, optochiasmatic, basal exudates, things like that. And don't forget mechanisms. Now that so much on cytokine storms, tissue destruction through several inflammatory mediators, adhesion molecules, like we today learned mechanisms of cerebral malaria, you're going to get some or other thing in your question papers on mechanisms as well. And then management, obviously, deliberately I picked out critical evaluation of neurosugerry. As you can see, not each therapy has a blanket role, and it has to be utilized judiciously, and that also you have to bear in mind. I think that's what I wanted to say. I would request my speakers to give in their thoughts as to how to prepare and how to make use of the information as well. So Dr. Kulkarni, Dr. Sakre, Dr. Takrakar, please express your thoughts on this kind of a session. That's what I had to say. Sakre?
Same thing, like I concur with what you have mentioned. Like practical aspects, generally no, but theoretical aspects, mechanisms, sometimes they are difficult to remember. And
Yes.
We lose touch verbally.
Absolutely. So we need to prepare ourselves for this theory. Dr. Kulkarni? See there? Hello?
Did you ask any question? Yes.
No. So what suggestions would you give to the preparing PGs?
Basically, in an infection disease, one must in an infection disease, probably it's a good idea that you look at various aspects of it, the types of complications. If there are newer therapies, the imaging modalities that help us diagnose, and of course, a lot of new investigations which have come up in infections, because every year you will hear newer kind of investigation which would come up. So it's worthwhile that you should keep pace with this. You must know what are the newer things happening as far as diagnosis. You hear every year a new TB related and investigation which comes up. It stays here for some time and then disappears. But it is a hot topic for at least 2-3 years. It may not remain for a long period, but for 2-3 years, it is a hot topic. So you must know about what's happening as far as infection investigations are concerned. You would get newer infections every time. We know that there was one fungal infection which had occurred through the solumetrol, which was given intrathecally a few years back. It remained for 2-3 years. It was a hot topic for a few years. So you must know some similar infections for some time. So they may be a hot topic for a few years. And then, of course, new drugs which are coming up. Every year you hear new TB-related drugs. So you must know about the new drugs which are coming up.
Absolutely. Dr. Takrakar, you want to say something? Hello? I think he's gone. So see, for our country, you have to be thoroughly prepared with this particular section of neuroinfections. And through these lectures, we've brought out so many important points, and there are many. And as you go on reading, try and formulate your own points and your own short notes. and that would help you make your preparation more and more, compact for the exam. I think with that, I end this session. Thank you all my speakers. Lot of efforts put in. These short notes will become available on the Dropbox, and please make use of them. Thank you.
Thank you.
Good night. Good night.